The numbers say it all. In 2014, tuberculosis rival HIV/AIDS is the leading cause of death from infectious diseases, according to a World Health Organization report. TB killed 1.1 million people globally in 2014. And India is the world's TB hotspot as it accounts for 23% of the global cases and the most number of deaths. 220,000 Indians died out of TB in 2014. That is 1 every 2 minutes. So I have with me today Dr. Zarir Udwadia, one of the foremost TB doctors in the country, to tell us about the magnitude of the TB problem. Dr. Udwadia, welcome to the show.
Thank you.
Now, let me begin with tuberculosis is generally considered a poor man's disease, but we have the likes of superstar Amitabh Bachchan, who's claimed to be a TB survivor. He's also now the ambassador for the Mumbai Mission Control. The late Prime Minister Indira Gandhi also contracted TB. So can the affluent to the middle class say, well, TB is not our disease?
You know, TB is an airborne pathogen and really no one is immune to it. It's a myth to think that the rich are protected. The spread of TB, after all, doesn't involve the physical contact, say, of Ebola. It doesn't require the sexual intimacy of HIV. One cough, one sneeze, and literally you are showered with millions of droplets of infectious TB bacilli. The driver in a Mercedes may have it and cough, and the rich business magnate at the back seat may very well get it. So the TB bacillus respects no borders. It draws no lines between who is rich and who is poor. And when you live in an endemic area like Bombay's, I would say Bombay is really at the center of India's TB problem for many reasons which we'll discuss later. I would say that no one is immune from tuberculosis, and I'd go one step further and say no one is immune from its drug-resistant variety as well.
Correct. So it's a social disease which gets transmitted like, it can spread like wildfire.
A social disease in that the poor are more prone to it, yes,
correct,
because of malnourishment, you follow. They're more afflicted by it because they find it more difficult to cope with the expense of managing this disease, and the costs are considerable. But in a sense, it has crossed the boundary of being just a poor man's disease and is permeated through society.
Okay, so the perennial problem that we face is the adherence to medicines or treatment. How can we create a system around that? Because a breadwinner of a family may say, well, I have to go to work, and he may go to work without a mask or anything. So how can we really look at that?
No other infectious disease I know has treatment which is quite so prolonged.
Correct.
For the average case of TB, 6 months is the mean treatment duration. And even that is a long period of time for you to be taking drugs continuously. For a patient with drug-resistant TB, which we alluded to earlier, the treatment stretches on for about 2.5 or 3 years. You follow? It's expensive drugs, it's toxic drugs, it's huge number of drugs, a big pill burden to be taken every day. So one of the principles of TB treatment is that we cannot rely on the patient to be taking his or her drugs on their own in a sensible way, because adherence is so important. And out of this rose the principle of DOTS. DOTS means direct observation of treatment. And whether it is a poor man or a rich man, again, they are as likely or unlikely to comply. You can't predict. And therefore, each dose should ideally be given under supervision. Now, in our government sector, that supervision sadly involves the patient actually making the long trek across the city, often to the nearest DOTS center, and taking his drugs there under supervision. In the private sector, that is not required often, and that is one of the reasons why TB treatment is so chaotic in the private sector, because you cannot rely on the patient 100% taking his drugs as they should. In other parts of the world, DOTS has been made more friendly. Often the social worker or the DOTS treatment worker goes to the patient's house, goes to the patient office, works out a time that is most comfortable and suitable for him. Because as you correctly said, for a poor patient, it's often, do I fill my stomach with food by working that day for the daily wage worker, or do I go across to the DOTS center where I will waste half the day, get my drugs and come back?
So the government programs like the revised National TB Control Program, which follows the DOTS model,
sure,
WHO model. So then has it been effective? Can we really say in some ways the TB numbers is on a decline?
The DOTS program has been very effective for the average patient with TB. India's DOTS TB program has been hailed as a global success and a global model. DOTS coverage is close to 100% across the country. So while it has really helped the patient with drug-sensitive TB, the straightforward TB, it has miserably failed, in my opinion, the patient with the drug-resistant TB, which is the kind of TB that I battle at least every day at the Hinduja Hospital.
Okay, so coming to the drug-resistant TB, which you and your team at Hinduja had alerted the world about its existence in India way back in 2011. So now, 4 years hence, what is the position that we are in?
The position is just as bad. We continue to see patients with the most highly resistant strains, resistant to not just 2 drugs, which is by definition MDR-TB, or 4 drugs, which is by definition XDR-TB, extremely drug-resistant TB, or extensively drug-resistant TB, but sometimes resistant to 8, 9, or even the 12 drugs that we described when we first spoke of totally drug-resistant TB. That title gave us a lot of infamy, I should say. We weren't being critical of the program directly when we described them. We were just describing a resistance pattern. We weren't saying these patients were untreatable or shouldn't be treated. In fact, we've been striving and making every effort to treat even this hardcore group of very resistant patients, with good success in some of them. But we are pointing out that as TB treatment gets more and more chaotic, we are seeing worse and worse strains of TB, more and more resistant strains of TB, some which are close to impossible to treat just because we don't have available drugs. A lot of changes occurred after 2011 though.
Yeah.
After our description, TB became a notifiable disease. Can you imagine that a disease which is India's major public health care problem by far was not even notifiable? So we didn't have a true idea of the extent of the problem. More money went up into the TB budgets of the city and the country, funding improved. TB just basically came up onto the global and Indian radar again. So that was the good that came out of that article. And it received a lot more attention, which it should. Because look, TB is without doubt our biggest public health problem. And I think it's scandalous and a tragedy really that we haven't responded appropriately to it.
An article makes a very ironical statement that TB is made in India and we are the world's exporters of TB, and we really don't want the credit for it. But then do we blame our healthcare system for it, the way it is, like you say, chaotic?
We do. It's not now, but it's been decades of neglect. We are guilty of complacency, our program is. They focused on the low-lying fruit, which is the average drug-sensitive TB patient, ignored the more difficult to treat patient. Because look, I can treat I can treat one MDR TB patient and in that sum of money treat about 400 drug sensitive patients. It's very expensive, labor intensive, lab intensive to treat one of these patients. So really calling it realpolitik, our program has initially ignored the MDR TB problem, pretended it didn't exist. I would call it public policy paralysis, allowing the numbers to slowly escalate. And now when it's out there in the open and the world says that India is the largest storehouse of not just TB but also drug-resistant TB, we have woken up and need to act fast.
So what would you say maybe are the 3 or 4 key steps that we really need to take to somehow at least, reduce the impact?
Well, first of all, we need to accept that this is our biggest public health problem. It would be scandalous not to. We have great new tests to diagnose it effectively. In the old days, diagnosing MDR TB meant a sending off a culture which took about 8 weeks to come back positive. In that time, the patient was getting more sick, was on inappropriate treatment, and spreading a virtually untreatable strain through a community. We now have a test called the Gene Expert, which can diagnose in a few hours that he or she is very likely to be MDR TB. So we need to have this test across the country. In South Africa, this test has replaced routine sputum testing.
Okay.
Now that might be a huge burden and expense on the existing TB system, but at least have more machines across the country. Guess how many we have across the breadth and length of this country of 1.2 billion? 120 machines, of which 4 or 5 are located in Hinduja. So we need these machines disseminated across the country because it's an easy test to do. So diagnose it more accurately and more quickly is the second suggestion. And then when you've made that diagnosis, treat these patients effectively.
Correct.
Treat them appropriately, follow general medical principles, treat treat them with sympathy and empathy, because I can't tell you how difficult this disease is for the patient to cope with, even at a mental level. What else is needed? Well, then there are the intangibles. There is the social support that's needed, the grinding poverty that many of these patients need to be brought out of. You follow? Because TB is not just a medical disease. There are so many social, political, and economic derivatives as well that go into this disease. More funding is needed. Our TB budget of 400 crores is woefully inadequate. And sadly, I heard that the allotment to TB is coming down at a time when it should really be escalating, which again sounds scandalous to me. So more funds are needed. You know, this machine I talked about, even if 15 or 20% of the people who need the test had it, just that would exhaust the whole program's budget for the year. So we are talking of budgeting on a far bigger scale, and I don't see that commitment. I don't see that government commitment yet.
So these awareness campaigns or awareness programs now, Amitabh Bachchan must be doing for Mumbai, but do we really need, and how can we really create an awareness?
I think it's needed, and on a much larger scale. I mean, I don't see the kind of posters and signs on every bus stop and in between every TV program saying, look, this is a highly infectious disease. It is spread by coughing. Cover your mouth when you cough. Wear a mask. If you've been coughing for more than 2 weeks, visit your local DOT center. Give a sputum sample off. Have an X-ray done. I don't see that kind of awareness. Most of my patients are not even aware that it is an infectious, transmissible disease. Even patients from well-off strata.
Okay. So if you, if you go down to basics, are we saying that it's also on the rise because we don't eat nutritious food, we are unhealthy lifestyles?
That's a good point. There are a lot of non-communicable factors which have made TB even more entrenched in our country. There's a strong link between TB and malnutrition. And you'd be surprised to know that India has more malnourished kids than sub-Saharan Africa in terms of numbers. And the link between your nutritional status and your chance of getting TB and your ability to successfully fight it off is now established. So that's one factor. The link with diabetes. India is the diabetes capital of the world, as you must know. And there's a strong link between diabetes and TB. The link with smoking. Smokers are more likely to get TB, find it more difficult to fight it off. We are a country with the highest number of smokers, along with China, for example. The link with indoor pollution and biomass exposure, where in villages, for example, people use wood and coal fires in the house, poorly ventilated. These are all non-communicable factors which are known to impact directly on TB.
Is there some way you can say what is the economic impact of TB?
Huge. The economic burden of TB, I'll tell you, a study recently published showed that it costs the country about 23 billion. 23 billion is the direct and indirect cost to the exchequer of tuberculosis annually in this country. We are talking of direct and indirect costs. Remember, time off work is one factor as well. When a patient is very unwell with TB, there are periods of months when he may not be able to work. So you need to factor that in as well. And we're doing an economic study in our department, and the cost of treating patients in private, especially if they have extrapulmonary TB, spinal TB, glandular TB, need surgeries as well, runs to a staggering average of about 3 or 4 lakhs, and sometimes as high as 20 lakhs. Now, how is the average person from across the road to afford that kind of sum? These are private patients and can cope with difficulty. But how does the private patient manage? And remember that about 70% of TB patients would choose to go private. Even the impoverished farmer somewhere in Madhya Pradesh or Uttar Pradesh, because he thinks so poorly of our healthcare system, would sell his cattle but choose to go private to the wrong doctor for sure, to a homeopath, a quack, an Ayurved. You know, the ratio of MBBS to non-MBBS doctors in this country is 1:17. So by default, almost they would be attracted to this category of doctors who would only give him a bad prescription, only serve to amplify resistance and make it more difficult for his TB to be treated.
Yeah, that's what I was going to ask you. Do we need to in some way keep a panel of doctors, not every every doctor kind of analyzing TB, some panel of doctors where the doctors, government says this is a system.
We need some kind of legislation for sure, especially for drug-resistant TB. There are guidelines, but they're never followed in our country, as you know, and this chaos is one of the reasons why the germ has thrived over the decades. But of course, you know, I think it's criminal that a person who's a homeopath or say a gynecologist, no one will say no to treating a patient with TB initially at least. And it's only later when the problem becomes more complicated that they send the patient to a specialist. So I'm not saying that drug-sensitive TB can only be treated by a panel of TB, because that panel would be overwhelmed, believe me, by the huge patient load. But surely the more difficult type of TB, the patients with MDR or XDR or beyond TB, should be seen by someone at least who is medically competent to see them. And the government has to work out who and how.
UN has a target to eradicate TB, malaria and AIDS by 2030. Will India be anywhere close to eradicating TB? Can we do something like we did for polio?
I'm an optimist about most things, but I'm also a realist. And if we continue on our present trajectory, there is no way we will reach that target.
And do organizations need to play a role, because somewhere, you know, a breadwinner or somebody who's earning a salary has to stay away from work for a long time? Do they have to also come in and
Absolutely.
support?
I think it would be irresponsible of the wealthier part of our society not to play their role. And in fact, we've gone around almost with begging bowls in our hands to rich families, corporates, and urged for funds for treatment of these patients.
So like you said, you know, most patients would finally come to the private sector, even in the rural areas. So is the whole effort of the government really being mitigated, the money and everything?
Absolutely. Till this dysfunctional relation between the private and public sector is bridged, and people have been talking of this public-private partnership. This term has been thrown around from WHO to our Indian government over the decades again. Till that becomes a reality, we will not see progress, because of this one fact that 70% of patients choose to go private to start with. And we've looked at the quality of some of those private prescriptions. We did a study at Dharavi a few years ago, which received a lot of attention again, and made us look very notorious, because we showed that we asked 100 practitioners in Dharavi how they would treat a patient with MDR-TB, and out of those 100 prescriptions, we audited them and said that only 2 or 3 would pass off as appropriate, just appropriate pass prescriptions. All the others were more costly, more expensive, inappropriate, and would have served only to amplify resistance. So if the patient came in with MDR-TB, if he followed that prescription, he would end up being even more sick. So we need to educate our private practitioners.
Okay, finally, if you can just communicate what is really the seriousness of drug-resistant TB when a patient gets it, and also what is the message you would give the government?
Seriousness of TB first. This is a disease where huge numbers of Indians are affected, where there are 300,000 deaths every year, where there is 1 death every 2 minutes as we speak from tuberculosis. A scandalous statistic that has not changed over the decades the program has been in place. That's not changed, whatever progress the program may claim to have made. So recognize the gravity of that situation, and recognize that while the simple type of TB is easy to treat, it has a more sinister doppelganger, MDR-TB, XDR-TB, which when treated badly will only get worse. These patients stay alive longer. They don't die quickly. They're alive for years. And the average MDR patient is infecting 10 or 20 other close contacts every year. That is the data. So you can imagine how you have the seedlings of a real epidemic on your hands. It wouldn't be an exaggeration to say that India has an MDR-TB epidemic on its hands.
Okay, and the message to the government you would like to give
is to wake up, recognize the problem and admit it, invest more in terms of funding and infrastructure, and reach out and embrace each and every TB patient and try and treat them irrespective of their resistance pattern. It would be morally, socially, economically and medically wrong to do otherwise.
Okay, Dr. Udwadia, thank you very much.
Thank you.